Question 1. A 3-month-old infant is found unresponsive, apneic, and pulseless. A lone rescuer is present. What is the correct compression to ventilation ratio for this infant? A. 30 compressions to 2 ventilations. B. 15 compressions to 2 ventilations. C. 30 compressions to 1 ventilation. D. Continuous compressions without pauses. Answer: A. 30 compressions to 2 ventilations. This question assesses knowledge of basic life support, BLS, guidelines for infants, specifically the compression to ventilation ratio for a lone rescuer. The keyword lone rescuer is crucial here, as it dictates the ratio. For a single rescuer performing CPR on an infant or child, the recommended ratio is 30 compressions to 2 ventilations to minimize interruptions in chest compressions. If 2 rescuers were present, the ratio would be 15:2. Always prioritize continuous, high-quality chest compressions while ensuring adequate ventilation. Question 2. A 5-year-old child presents with a sudden onset of rapid heart rate, pallor, and poor perfusion. The rhythm strip shows a regular narrow complex tachycardia at a rate of 220 bpm. The child is irritable and has diminished peripheral pulses. What is the most appropriate initial pharmacological intervention? A. Epinephrine. B. Amiodarone. C. Adenosine. D. Atropine. Answer: C. Adenosine. This question tests the management of symptomatic narrow complex tachycardia in a child, specifically supraventricular tachycardia, SVT. The keywords rapid heart rate, pallor, poor perfusion, regular narrow complex tachycardia at 220 bpm, and irritable with diminished peripheral pulses all indicate an unstable SVT. Adenosine is the first-line medication for unstable SVT with adequate perfusion, after vagal maneuvers fail, as it temporarily blocks AV nodal conduction to terminate the re-entry circuit causing SVT. For example, administering a rapid 4/IO bolus of adenosine can often convert the rhythm back to normal sinus. Always remember that for a child with unstable SVT, adenosine is the go-to medication to restore a normal heart rhythm. Question 3. What is the recommended depth for chest compressions in a child, approximately 1 year to puberty? A. At least 1 inch, 5 cm. B. At least 5 inches, 4 cm. C. At least 2 inches, 5 cm. D. At least 4 inches, 6 cm. Answer: C. At least 2 inches, 5 cm. This question focuses on the technical aspects of high-quality cardiopulmonary resuscitation, CPR, for children. The keyword child, approximately 1 year to puberty, specifies the age group for which the compression depth needs to be known. For effective chest compressions in a child, the chest must be compressed at least 2 inches, 5 cm, or about 1/3 the anterior-posterior diameter of the chest. This depth ensures adequate blood flow to vital organs during cardiac arrest. It's important to differentiate this from infant depth, 5 inches, or adult depth, 2-4 inches. Always press hard and fast, ensuring full chest recoil, to maximize blood circulation. Question 4. A 7-year-old child is in cardiac arrest. The cardiac monitor shows ventricular fibrillation, VF. After 2 minutes of high-quality CPR, what is the next most appropriate intervention? A. Administer atropine. B. Deliver an unsynchronized shock, defibrillation. C. Administer epinephrine. D. Check for a pulse. Answer: B. Deliver an unsynchronized shock, defibrillation. This question assesses the management of a shockable rhythm during pediatric cardiac arrest. The keywords cardiac arrest and ventricular fibrillation, VF, indicate a critical, life-threatening situation requiring immediate intervention. Ventricular fibrillation is a chaotic electrical activity in the heart that results in no effective blood flow, making it a shockable rhythm. After initial CPR, the priority for VF is immediate defibrillation to reset the heart's electrical activity. For example, if you see VF on the monitor, the next step is to charge and deliver the shock as quickly as possible. Remember, VF equals defib. Question 5. Which of the following is considered a sign of compensated shock in a child? A. Hypotension. B. Altered mental status. C. Normal blood pressure with tachycardia. D. Bradycardia. Answer, C. Normal blood pressure with tachycardia. This question tests the recognition of compensated shock in a pediatric patient. The keyword compensated shock implies that the body is still maintaining vital organ perfusion despite a decrease in circulating blood volume or cardiac output. In compensated shock, a child's body will try to maintain blood pressure by increasing heart rate, tachycardia, and peripheral vascular resistance, often resulting in a normal blood pressure despite other signs of poor perfusion like cool extremities or prolonged capillary refill time. Hypotension indicates decompensated shock, a much more severe and immediate threat. For instance, a child with gastroenteritis and dehydration might show tachycardia and slightly prolonged capillary refill but still have a normal blood pressure, indicating compensated shock. Always look for a fast heart rate and other signs of poor perfusion even if blood pressure is normal, as these are early warnings. Question 6. What is the recommended initial intravenous/intraosseous, for/IO, dose of epinephrine for pediatric cardiac arrest? A. 0.01 mg/kg, 0.1 ml/kg of 1:10,000 solution. B. 0.1 mg/kg, 0.1 ml/kg of 1:10,000 solution. C. 0.01 mg/kg, 0.01 ml/kg of 1:10,000 solution. D. 0.05 mg/kg, 0.5 ml/kg of 1:10,000 solution. Answer, A. 0.01 mg/kg, 0.1 ml/kg of 1:10,000 solution. This question targets a fundamental pharmacological aspect of pediatric cardiac arrest management. The keywords initial intravenous/intraosseous, for/IO, dose of epinephrine are critical, emphasizing the specific route and first administration in this life-threatening situation. The correct dose is 0.01 mg/kg of a 1:10,000 concentration solution, which translates to 0.1 ml/kg. Epinephrine is a powerful vasoconstrictor and cardiac stimulant, used to improve coronary and cerebral blood flow during CPR. For example, if a child weighs 10 kilograms, the dose would be 0.1 mg, or 1 milliliter of the 1:10,000 solution. Always double-check your calculations and ensure you're using the correct concentration of epinephrine during a resuscitation. Question 7. A 2-year-old child presents with sudden onset of stridor, coughing, and inability to speak after playing with small toys. The child is conscious but appears cyanotic. What is the most appropriate initial intervention? A. Administer albuterol via nebulizer. B. Perform chest compressions. C. Perform back blows and abdominal thrusts, Heimlich maneuver. D. Prepare for immediate intubation. Answer C. Perform back blows and abdominal thrusts, Heimlich maneuver. This question addresses the management of a severe foreign body airway obstruction in a conscious child. The keywords sudden onset of stridor, coughing, inability to speak, playing with small toys, and conscious but appears cyanotic clearly indicate a severe airway obstruction. Since the child is conscious, the immediate intervention for a severe foreign body airway obstruction in a child is to perform cycles of back blows and abdominal thrusts, Heimlich maneuver. This technique aims to dislodge the object. For example, if a child chokes on a small toy, these maneuvers are crucial to clear the airway. Remember, for a conscious child with a severe foreign body airway obstruction, mechanical thrusts are the priority. Question 8. During a pediatric resuscitation, team leaders should clearly assign roles to team members. Which element of effective team dynamics does this best represent? A. Closed-loop communication. B. Knowing your limitations. C. Clear roles and responsibilities. D. Constructive intervention. Answer C. Clear roles and responsibilities. This question focuses on essential aspects of effective team dynamics in a pediatric resuscitation. The keywords team leaders should clearly assign roles directly point to the concept being tested. Establishing clear roles and responsibilities ensures that every team member knows their specific task, reducing confusion, avoiding duplication of effort, and preventing critical tasks from being missed. This structured approach helps the team function smoothly and efficiently during high-stress situations. For example, explicitly stating "you are compressions" or "you are airway" ensures everyone understands their assignment. Always ensure roles are clearly defined at the start of any resuscitation. Question 9. A 10-year-old child is in respiratory distress. Assessment reveals increased respiratory rate, moderate retractions, and accessory muscle use. The child is alert, speaking in short sentences. Based on these findings, how would you classify this child's respiratory status? A. Respiratory failure. B. Respiratory arrest. C. Severe respiratory distress. D. Moderate respiratory distress. Answer D. Moderate respiratory distress. This question tests the ability to classify respiratory emergencies in children. The keywords increased respiratory rate, moderate retractions, and accessory muscle use indicate significant effort, but the child is alert and speaking in short sentences, meaning they are still maintaining some level of compensation. Moderate respiratory distress is characterized by these signs, showing the child is working harder to breathe but has not yet reached the point of impending failure where mental status would likely be altered or breathing would become ineffective. For example, a child with an asthma exacerbation might exhibit these signs. Keep in mind that a child's level of consciousness and ability to speak are important clues to their respiratory status. Question 10. What is the maximum initial dose of adenosine that can be given to a child for supraventricular tachycardia, SVT? A. 0.01 mg/kg. B. 0.1 mg/kg. C. 0.2 mg/kg. D. 0.3 mg/kg. Answer C. 0.2 mg/kg. This question specifically asks about the maximum initial dose for adenosine in pediatric SVT. The keyword maximum initial dose is important because adenosine has a specific escalating dosage regimen. While the first dose is 0.1 mg/kg, if the first dose is ineffective, the second dose, which is still considered an initial attempt if the first fails, is doubled to 0.2 2 mg/kg. Therefore, 0.2 mg/kg is the maximum single initial dose that can be administered in this sequence. For instance, if a 10 kg child receives 1 mg and it doesn't work, the next dose would be 2 mg. Always remember that adenosine is given as a rapid 4/IO bolus followed by a flush. Question 11. What is the primary method for confirming endotracheal tube, ETT, placement in a pediatric patient after intubation? A. Auscultation of breath sounds over the lungs and epigastrium. B. Symmetric chest rise with ventilation. C. Continuous quantitative waveform capnography. D. Visualization of the tube passing through the vocal cords. Answer: C. Continuous quantitative waveform capnography. This question assesses the gold standard for confirming endotracheal tube, ETT, placement in pediatric patients. While auscultation, symmetric chest rise, and visualization are initial and important indicators, the keyword primary method refers to the most reliable and continuous confirmation technique. Continuous quantitative waveform capnography provides real-time measurement of exhaled carbon dioxide, which reliably confirms the ETT is in the trachea and not the esophagus, and it also monitors the quality of ventilation. For example, a consistent square waveform on the capnograph after intubation indicates proper placement and good ventilation. Always rely on capnography for definitive and ongoing ETT confirmation. Question 12. A 4-year-old child in cardiac arrest has received 2 doses of epinephrine and appropriate defibrillation for VF. The rhythm remains VF. What antiarrhythmic medication should be considered next? A. Atropine. B. Lidocaine or amiodarone. C. Magnesium sulfate. D. Sodium bicarbonate. Answer: B. Lidocaine or amiodarone. This question tests the advanced management of refractory ventricular fibrillation, VF, in pediatric cardiac arrest. The keywords cardiac arrest, VF, and 2 doses of epinephrine and appropriate defibrillation indicate a persistent, life-threatening arrhythmia that has not responded to initial treatments. For refractory VF or pulseless ventricular tachycardia, private, after initial defibrillation and epinephrine, an antiarrhythmic medication like amiodarone or lidocaine is recommended to help stabilize the heart's electrical activity. For example, after 2 shocks and 2 doses of epinephrine, administering amiodarone could help convert the VF rhythm. Remember that these medications are used to make the heart more receptive to defibrillation. Question 13. What is the recommended chest compression rate for high-quality CPR in children? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer: C. 100 to 120 compressions per minute. This question focuses on another critical component of high-quality cardiopulmonary resuscitation, CPR, for children, the compression rate. The keyword recommended chest compression rate highlights the specific range to aim for. For both infants and children, the recommended rate for chest compressions is 100 to 120 compressions per minute. This rate ensures that enough compressions are delivered to maintain adequate blood flow to vital organs during cardiac arrest. For example, listening to the rhythm of "Stayin' Alive" can help you maintain the correct pace during compressions. Always strive for a consistent, brisk rate within this range. Question 14. An infant presents with poor muscle tone, weak cry, and a heart rate of 50 bpm despite adequate ventilations with a bag mask device and chest compressions. What is the most appropriate medication to administer next? A. atropine, B. Adenosine, C. Epinephrine, D. Dextrose. Answer, C. Epinephrine. This question addresses the management of symptomatic bradycardia that is unresponsive to ventilation and compressions in an infant. The keywords poor muscle tone, weak cry, heart rate of 50 bpm, and despite adequate ventilations, and chest compressions indicate severe, unresponsive bradycardia. In pediatric bradycardia with poor perfusion that persists despite oxygenation, ventilation, and chest compressions, epinephrine is the drug of choice to increase heart rate and myocardial contractility. For example, if an infant's heart rate remains dangerously low even after these initial efforts, epinephrine can help stimulate the heart. Always remember that epinephrine is used to treat clinically significant bradycardia unresponsive to initial interventions. Question 15. A 9-year-old child is unresponsive and pulseless. The PALS team is performing CPR. After 2 minutes of CPR, the monitor shows asystole. What is the next most appropriate action? A. Administer an unsynchronized shock. B. Administer epinephrine. C. Insert an advanced airway. D. Check for a pulse. Answer, B. Administer epinephrine. This question tests the management of a non-shockable rhythm, specifically asystole, during pediatric cardiac arrest. The keywords unresponsive and pulseless, asystole, which means no electrical activity, and after 2 minutes of CPR indicate a critical, non-shockable cardiac arrest scenario. For asystole, defibrillation is not effective because there is no electrical activity to shock. The primary treatment for asystole is high-quality CPR and the administration of epinephrine to try and stimulate electrical activity and increase coronary perfusion. For example, after 2 minutes of CPR, you would immediately give epinephrine while continuing compressions. Always remember that asystole and PA, pulseless electrical activity, are treated with CPR and epinephrine, not defibrillation. Question 16. Which of the following is a common reversible cause of cardiac arrest, one of the H's and T's? A. Hyperthermia. B. Hypertension. C. Hypoglycemia. D. Hypernatremia. Answer, C. Hypoglycemia. This question assesses knowledge of the common, reversible causes of pediatric cardiac arrest, often referred to as the H's and T's. The keyword reversible cause and H's and T's points directly to these identifiable and treatable conditions. Hypoglycemia, low blood sugar, is one of the important H's that can lead to cardiac arrest if not corrected, especially in children. Other H's include hypovolemia, hypoxia, hypothermia, and hyper-hypokalemia. For example, a child with diabetes who misses a meal might become hypoglycemic and, if severe enough, could progress to cardiac arrest. Always consider and aggressively treat these reversible causes during resuscitation efforts. Question 17. A 6-month-old infant presents with severe respiratory distress, marked retractions, and grunting. The infant is lethargic and has a significantly diminished breath sounds. What is the most likely classification of this infant's respiratory status? A. Mild respiratory distress. B. Moderate respiratory distress. C. Respiratory failure. D. Respiratory arrest. Answer, C. Respiratory failure. This question evaluates the ability to identify impending respiratory failure in an infant. The keywords severe respiratory distress, marked retractions, grunting, lethargic, and significantly diminished breath sounds collectively paint a picture of an infant who is no longer compensating adequately. Lethargy and diminished breath sounds are particularly alarming signs, indicating the child's respiratory muscles are fatiguing and gas exchange is failing. For instance, an infant with severe bronchiolitis might progress to this state, needing immediate advanced airway intervention. Always recognize that changes in mental status and diminished breath sounds often signal progression from distress to failure. Question 18. What is the recommended method for checking a pulse in an infant during a resuscitation attempt? A. Carotid pulse. B. Femoral or brachial pulse. C. Radial pulse. D. Pedal pulse. Answer, B. Femoral or brachial pulse. This question targets a critical skill in pediatric basic life support, pulse assessment in infants. The keyword infant specifies the age group, which has unique anatomical considerations for pulse checks. For infants, the femoral pulse, in the groin, or the brachial pulse, in the upper arm, are the most accessible and reliable locations to check for a pulse. The carotid pulse is often difficult to palpate in infants due to their short necks. For example, if you suspect cardiac arrest in an infant, you would feel for a brachial pulse on the inside of their upper arm. Always remember to check for a pulse for no more than 10 seconds to minimize interruptions in CPR. Question 19. What is the most common cause of cardiac arrest in children? A. Primary cardiac event. B. Sudden unexplained death. C. Progressive respiratory failure or shock. D. Traumatic injury. Answer, C. Progressive respiratory failure or shock. This question addresses a fundamental concept in Pediatric Advanced Life Support concerning the etiology of cardiac arrest. The keyword most common cause highlights a key difference between adult and pediatric cardiac arrest. Unlike adults, where primary cardiac events are common, children typically experience cardiac arrest secondary to progressive respiratory failure or decompensated shock. This means that if early interventions can prevent respiratory failure or shock from worsening, cardiac arrest can often be avoided. For instance, a child with severe asthma who progresses to respiratory failure, or a child with severe dehydration who develops decompensated shock, are at high risk for cardiac arrest. Always remember to address respiratory and circulatory problems quickly to prevent cardiac arrest in children. Question 20. What is the target end-tidal CO2, EtCO2, range that indicates effective chest compressions during pediatric CPR? A. Less than 10 millimeters of mercury. B. 10 to 20 millimeters of mercury. C. Greater than 20 millimeters of mercury. D. 35 to 45 millimeters of mercury. Answer, C. Greater than 20 millimeters of mercury. This question assesses the use of end-tidal CO2, EtCO2, monitoring as a measure of CPR quality. The keywords target end-tidal CO2, EtCO2, range and effective chest compressions are crucial, as EtCO2 directly reflects the amount of carbon dioxide being delivered to the lungs, which is proportional to cardiac output during CPR. An EtCO2 value consistently greater than 20 millimeters of mercury during CPR suggests that chest compressions are producing adequate blood flow to the lungs and body. If EtCO2 falls below 10 millimeters of mercury, it indicates poor quality CPR and mandates improving compression technique. For example, seeing EtCO2 jump above 20 millimeters of mercury after adjusting compression depth or rate provides real-time feedback that your compressions are more effective. Aim for EtCO2 above 20 millimeters of mercury as a vital sign of good CPR. Question 21. A 3-year-old child presents with a sudden onset of generalized urticaria, wheezing, and hypotension after eating peanuts. What is the most appropriate initial medication to administer? A. Diphenhydramine. B. Albuterol. C. Epinephrine intramuscularly. D. Methylprednisolone. Answer: C. Epinephrine intramuscularly. This question describes a classic presentation of anaphylaxis, a severe allergic reaction, in a child. The keywords generalized urticaria, wheezing, and hypotension are hallmarks of anaphylactic shock. Epinephrine administered intramuscularly is the first-line and most critical treatment for anaphylaxis because it rapidly counteracts the life-threatening symptoms, improving breathing and blood pressure. While other medications like diphenhydramine and albuterol may be used as adjuncts, epinephrine directly addresses the systemic allergic reaction. For example, if a child with a known peanut allergy develops these symptoms, immediate IM epinephrine is life-saving. Always remember that for anaphylaxis, epinephrine is the definitive initial treatment. Question 22. When delivering ventilations with a bag mask device to a child with an advanced airway in place during cardiac arrest, how often should breaths be given? A. Every 3 to 5 seconds, 12-20 breaths per minute. B. Every 6 seconds, 10 breaths per minute. C. Every 10 seconds, 6 breaths per minute. D. Continuously with chest compressions. Answer: B. Every 6 seconds, 10 breaths per minute. This question focuses on appropriate ventilation rates during pediatric cardiac arrest when an advanced airway is secured. The keyword advanced airway in place signifies that compressions and ventilations are no longer synchronized in a ratio. With an advanced airway, ventilations should be delivered at a rate of 1 breath every 6 seconds, or 10 breaths per minute, independently of chest compressions, which should be continuous. This avoids hyperventilation and helps maintain continuous chest compressions. For example, once an endotracheal tube is placed, the person ventilating would give a breath every time the second hand sweeps past a 6-second mark on a clock, while the compressions continue uninterrupted. Always remember that with an advanced airway, ventilation and compressions become independent. Question 23. What is the correct fluid bolus amount for a child in compensated hypovolemic shock? A. 5 milliliters per kilogram over 20 minutes. B. 10 milliliters per kilogram over 10 minutes. C. 20 milliliters per kilogram over 5 to 20 minutes. D. 30 milliliters per kilogram over 30 minutes. Answer: C. 20 milliliters per kilogram over 5 to 20 minutes. This question tests the fluid management for pediatric hypovolemic shock. The keywords fluid bolus and compensated hypovolemic shock indicate the need for rapid volume expansion. The standard initial fluid bolus for a child in any type of shock, except cardiogenicity, is 20 milliliters per kilogram of an isotonic crystalloid, administered rapidly over 5 to 20 minutes, then reassessing the patient. This helps restore circulating blood volume and improve perfusion. For example, a 15 kilograms child in shock would receive 300 milliliters of normal saline. Always administer fluid boluses quickly and reassess frequently to guide further management. Question 24. A PALS team is resuscitating a child. The team leader asks a team member, "Can you administer 0.01 mg/kg of epinephrine?" The team member responds, "Yes, I will give 0.01 mg/kg of epinephrine." Which communication technique is being demonstrated? A. Closed-loop communication. B. Call-out. C. Mutual respect. D. Role assignment. Answer A. Closed-loop communication. This question assesses understanding of effective team communication during resuscitation. The crucial element is the team member responds by repeating the order, confirming they heard and understood it. Closed-loop communication is a vital safety measure where the sender gives an order, and the receiver repeats the order back to confirm correct reception, ensuring no misunderstanding. This reduces errors and improves team efficiency, especially in high-stress environments. For example, if the team leader says, "Give 1 milligram of epinephrine," the responder repeating, "Giving 1 milligram of epinephrine," completes the loop. Always use closed-loop communication for critical tasks to prevent mistakes. Question 25. What is the recommended energy dose for the first unsynchronized cardioversion in a child with unstable ventricular tachycardia, VT, with a pulse? A. 0.5 J/kg. B. 1 J/kg. C. 2 J/kg. D. 4 J/kg. Answer B. 1 J/kg. This question tests the appropriate energy dose for the first cardioversion attempt in a child with a specific unstable rhythm. The keywords first unsynchronized cardioversion, child, and unstable ventricular tachycardia, VT, with a pulse are critical. For unstable ventricular tachycardia with a pulse, where the child has signs of poor perfusion but is not in cardiac arrest, synchronized cardioversion is generally preferred. However, if synchronization causes a delay or is not possible, an unsynchronized shock, defibrillation, may be necessary. The initial energy dose for this is 1 J/kg. For example, if a child weighs 20 kilograms, the first dose would be 20 joules. Always ensure the child is adequately sedated if conscious, and prepare for higher doses if the first attempt is unsuccessful.